Hello and welcome to the topic chest trauma in the surgery module. By the end of this topic, you should be able to define chest trauma, outline the mechanisms of chest trauma, recognize the clinical manifestations of chest trauma, describe the workup for chest trauma, and finally, discuss the management of patients with chest trauma. Let's get started. Before we begin, you should ask yourself, what is chest trauma? Chest trauma is an injury or injuries that happen towards the chest or thoracic area due to forces. Chest injuries include bruising or abrasions such as cuts and grazes to the chest area, rib fractures, and visceral organ injuries. Evidence has shown that chest injuries account for 25% of all deaths from traumatic injury. Chest trauma injury can range from thoracic wall contusions or lacerations to pneumothorax, flail chest, and even cardiac tamponade. So what are the mechanisms of chest trauma? There are three different mechanisms of chest trauma, which are blunt trauma, penetrating trauma, and compression injury. Blunt trauma occurs due to blunt force to the chest. Examples include automobile crashes or falls. Penetrating trauma is caused by projectile that enters the chest causing a small or large hole. Examples include gunshot wounds or stab wounds. Compression injury, on the other hand, happens when the chest is caught between two objects and it is compressed. Understanding the different mechanisms of trauma provides insight into the possible injuries sustained and decides the mode of management. Alternatively, to be more specific, chest trauma can be largely classified as immediately life-threatening, which is picked up during primary survey, or potentially life-threatening, which is seen in secondary survey. For primary survey, examples of immediately life-threatening conditions can be looked at in terms of airway, breathing, and circulation. In the airway assessment, look for any airway obstruction or tracheobronchial tree injury. Next, for breathing, check for any tension or open pneumothorax. And finally, in terms of circulation, look for any massive hemothorax, cardiac tamponade, or traumatic circulatory arrest. Let's now move on to secondary survey. Secondary survey helps with the identification of potentially life-threatening conditions. This includes aortic injuries, flail chest, myocardial contusion, rupture of the diaphragm, esophageal injury, and pulmonary contusion. Now we'll go through the life-threatening condition that you would need to look out for in your primary survey, starting with airway obstruction. The causes of airway obstruction may be due to direct trauma, either from the airway or surrounding structures, loss of pharyngeal tone, incorrect positioning, or contamination of the airway due to debris such as vomitus, blood, teeth, or other foreign bodies. Clinical manifestation-wise, we can divide it into partial or complete airway obstruction and at-risk airway. Some clinical features of partial airway obstruction are hoarse voice, noisy breathing, snoring, stridor, hypoxia or hypercarbia, gurgling from secretion, and signs of respiratory distress. In complete airway obstruction, the patient will have profound hypoxia, paradoxical movement of the chest and abdomen, inaudible breath sounds, and inability to speak or cough. Features suggestive of an at-risk airway includes the inability to swallow secretion, a low GCS score traditionally of 8 or below, the ability to comfortably tolerate an oral airway, and features of a condition potentially requiring deep sedation or general anesthesia. Your goal for the management of any airway obstruction is to ensure that the airway is patent and your patient is able to effectively be oxygenated. So how do you manage an airway obstruction? You need to first put the patient in an age-appropriate position, where the head will be put into a neutral position. One thing to bear in mind is to never perform head tilt chin lift. Instead, a jaw thrust would be more appropriate. Next, apply any gentle suction of the airway to remove any secretions, blood, or vomitus. You may also need to administer high-flow oxygen. If tolerated, use an oropharyngeal airway or nasopharyngeal airway once you made sure that head injury is unlikely. Lastly, if needed, intubate the patient. If not attended to immediately, airway obstruction may lead to respiratory failure, arrhythmias, cardiac arrest, and even death. Moving on to tracheobronchial injury, which comprises of injury occurring between the cricoid cartilage and the right and left main stem tracheal bifurcation. Injuries may be due to blunt or penetrating trauma or projectile injuries to the chest and neck. Some of the clinical features seen include respiratory failure, dyspnea, crepitus or subcutaneous emphysema, high riding hyoid bone, pneumomediastinum, Hammond sign, stridor, hemoptysis, dysphagia, and dysphonia. The initial modality for the evaluation of tracheobronchial tree injury is chest X-ray, where you may see subcutaneous emphysema, pneumomediastinum, or the fallen lung sign. This is where the lung is in a dependent position held on the hilum by its vascular attachment. The gold standard for detection of tracheal injuries would be your bronchoscopy, but take note of the patient's condition and act accordingly. Initial management of patients with distress or suspicion of tracheobronchial injuries must be started with immediate intubation, if possible under the guidance of flexible bronchoscopy. The priority here is to stabilize the patient and ensure adequate airway. Subsequent management may be conservative or surgical treatment depending on the injury. Conservative treatment may be considered for patients who are stable with no evidence of esophageal injury, open tracheal injury, difficulty with mechanical ventilation if intubation is needed, no development of mediastinal or subcutaneous emphysema, or signs of sepsis-related iatrogenic tracheobronchial injury. Now we move on to pneumothorax, which is when there is pocket of air between the two layers of the pleura, resulting in collapse of the lung. There are two types of pneumothorax, which are open and tension pneumothorax. Open pneumothorax is often due to blunt or penetrating trauma or even iatrogenic. Air enters the pleural space where the affected lung becomes compressed and collapses, which in turn causes the alveoli to become underventilated, causing ventilation-perfusion mismatching and intrapulmonary shunting. If the pneumothorax is large, hypoxemia occurs and acute respiratory failure quickly develops. In addition, increased pressure within the chest can lead to shifting of the mediastinum, compression of the great vessels, and decreased cardiac output. Clinical features include sudden chest pain, rapid and shallow breathing, shortness of breath, tachycardia, hypoxia, and sometimes dizziness and agitation. Additionally, you may notice an open chest wound or hear an audible sucking sound as air enters or an absence of breath sound and hyperresonant lung during auscultation and percussion. Usually, the diagnosis is made clinically, but imaging such as EFAS exam, CT scan, ultrasound, and chest X-ray may be helpful. However, if the patient is unstable and you are suspecting an open pneumothorax, proceed with immediate management rather than imaging. Management-wise, you would need to apply a 3-sided occlusive dressing to the wound to prevent air from entering during inspiration via the wound, but allow air to exit during exhalation. Otherwise, a tension pneumothorax may develop. Then, a chest tube may be further used to assist in breathing. Supplemental oxygen may be administered if hypoxia is severe, and long-term management includes surgical intervention to repair the open wound or any other injuries. Now let's talk about tension pneumothorax. This is a condition that occurs when air is allowed to enter the pleural space but not exit it. As air pressure increases inside the pleural space, the lung collapses and the mediastinum shifts to the unaffected side. This may be a result of spontaneous or traumatic pneumothorax. To confirm the diagnosis, percussion will reveal hyperresonance with decreased or absent breath sounds over the affected area. This is coupled with hypoxemia and hypercapnia as well as an evidently increased translucency on the affected side on chest X-ray. As the tension builds up, the trachea may deviate away from the affected site. It is important for you to recognize the features early to initiate prompt management, which includes supplemental oxygen therapy, needle decompression, and chest tube insertion. Complications of pneumothorax include respiratory failure in the event of complete pulmonary collapse, cardiac failure, hemodynamic shock, hemothorax in the case of trauma, and pneumomediastinum, to name a few. Next, hemothorax. Hemothorax is a condition when the pleural space fills with blood, which occurs due to lacerated blood vessels in the thorax. As blood increases, it puts pressure on the heart and the vessels in the chest cavity. In patients with hemothorax, you will notice that they are restless, tachypnic, have frothy and bloody sputum, diminished breath sounds on the affected side, tachycardic, and sometimes they have flat neck veins. The most important treatment for hemothorax is draining the blood out of the chest cavity using a chest tube. Surgical exploration in cases of traumatic hemothorax should be performed in the following circumstances. Evacuation of more than 1,000 ml of blood immediately after tube thoracostomy. This is considered a massive hemothorax. Continued bleeding from the chest defined as 150 or 200 milliliter per hour for 2 to 4 hours. And finally, if there is repeated need for blood transfusion to maintain hemodynamic stability. Let's talk about cardiac tamponade, which happens when there is elevated intrapericardial pressure due to a pericardial infusion compressing the heart, especially the right ventricle. Its etiology includes chest trauma, aortic dissection, acute pericarditis, and cardiac surgery. To remember the clinical manifestations of cardiac tamponade, you should be familiar with the Beck's triad, which consists of hypotension, muffled heart sound, and distended neck veins. Additionally, the patient may present with tachycardia, pulses, paradoxes, symptoms of right heart failure, or pallor. ECG finding includes low voltage QRS complexes and pulses alternans. If the patient is unstable and you suspect a tamponade, proceed immediately to the management. However, in all other patients, the diagnosis can be confirmed with echocardiography, either transthoracic echo or focus-assessed transthoracic echo. A pericardiocentesis is needed. For those who are stable, imaging guidance such as ultrasound or CT may be used, otherwise it's not needed. The patient should also be admitted for observation and referred if appropriate. Complications of cardiac tamponade are bleeding, perforation of surrounding structures and vessels, infection, and pericardial decompression syndrome. Finally, traumatic circulatory arrest. This is a condition when the heart ceases to beat due to blunt or penetrating trauma to the thoracic area. Usually, the patient presents most commonly with a pulseless electrical activity, followed by asystole or electromechanical dissociation and ventricular dysarrhythmia. Management-wise, you would need to perform basic life support and advanced cardiovascular life support, which is discussed in detail in the A&E module. Once underlying etiology is identified, the appropriate management is carried out. To summarize, chest injuries are common and often life-threatening in trauma patients. Therefore, rapid identification and treatment of these patients are paramount. This can be achieved through primary and secondary surveys, which can be referred to in the emergency department module. Airway management is vital and aggressive management is required for the management of most chest injuries. Remember the important presentations of chest trauma, which are airway obstruction, tracheobronchial tree injury, tension pneumothorax, open pneumothorax, massive hemothorax, cardiac tamponade, and traumatic circulatory arrest. These conditions need to be recognized and managed immediately, as any delay may cause death. We have come to the end of this topic. Thank you for your time.